Hello everyone, thank you for joining us for this webinar series, the Med Safety Exchange, a joint venture by the Institute for Safe Medication Practices Canada and the Canadian Patient Safety Institute. Just a reminder that this webinar will be recorded so that it's available to those who couldn't make it at this time. We have all the lines muted and we encourage any questions or comments to be typed to us in the chat box, and then we'll read them out loud at the end of the webinar during the discussion. I'm sure most of you are aware, but for those who may be joining us for the first time, the purpose of this webinar series is to provide another modality and platform whereby healthcare providers can share and learn from one another to minimize the recurrence of med incidents and optimize med safety in all care sites. Every webinar will have roughly the same structure but with different content. So this webinar will have one med incident analysis regarding the importance of careful medication dosing calculations for pediatrics and a description of a med safety program to encourage continuous quality improvement. This will be followed by the observatory for a med safety update and then finish up with a discussion period where we read out your comments and allow the speakers to elaborate. As in all webinars, anonymity is a choice for all those involved, so I'll only introduce speakers briefly to share as much or as little as they'd like about themselves and or their practice. I'd like to invite the first speaker to discuss an incident analysis involving pediatric dosing calculation errors and the tips to keep in mind to prevent recurrence.
Thanks, Alika. As a background, my name is Ian Stewart, and I've been practicing community pharmacy for the last 30 years in the Toronto area. In the time allotted to me today, I want to focus on the potential for errors when calculating doses for pediatric patients. There is usually an increased need for pharmaceutical calculations when prescribing or dispensing drugs for pediatric patients, because there's usually a lack of available dosage forms and concentrations that are appropriate for infants and children. Hence, there is often a need to extemporaneously compound unique drug formulations. A common example I see in practice is the compounding of dexamethasone oral liquid. In Ontario, if a pharmacist receives a prescription for a pediatric patient for dexamethasone 7 milligrams, the only product covered by the provincial drug plan is the extemporaneous compound of dexamethasone tablets in a solvent such as simple syrup. The pharmacist would therefore be required to calculate the total volume of liquid to be prepared, the final concentration, the total number of dexamethasone tablets, the volume of syrup needed, and the volume per dose. In addition, pediatric patients often require precise dosage measurements based on the child's age, weight, and the indication for use of the medication. Extreme care must be taken when performing these calculations, as an error can lead to the administration of an incorrect dose and possible patient harm. We know that pediatric patients are at increased risk of harm due to the incomplete development of their body organs and defense systems. There is also a heightened emotional component when an error involves pediatric patients. Both the child's parents and the healthcare provider involved are affected emotionally. Healthcare practitioners have reported becoming depressed and not being able to sleep after learning that their action or inaction led to a child's harm. Licensing bodies and the courts also view and handle errors involving children differently. One key factor which contributes to the calculation of an incorrect dose is the ambiguity in which recommended dosages are stated. The dose of a specific drug may be listed as 10 milligrams per kilogram per dose every 12 hours, or 10 milligrams per kilogram per day given at 12-hour intervals. On this packaging of Festin, the recommended dosage for treating otitis media is listed as 15 milligram per kilogram per dose given twice daily. However, on the package of Diaxin, the recommended dosage is listed as 15 milligram per kilogram per day given every 12 hours. This ambiguity can lead to an error, as the following example demonstrates. This written prescription for Zolvirax was given to the mother of a 9-year-old child with herpes stomatitis. The prescription was taken to a local pharmacy for processing. Upon checking the prescription, the pharmacist consulted with the child's mom and confirmed the child's weight and indication for use. An appropriate reference was also consulted, and the recommended dosage was determined to be 20 milligram per kilogram per dose 4 times daily for 5 days. Based on the child's weight of 22 kilograms and the correct dosage was calculated to be 440 milligrams 4 times daily for 5 days and not just 110 milligram. It would appear the prescriber calculated the dose as 20 milligrams per kilogram per day divided in 4 equal doses, or only a quarter of the recommended dose. It is easy to see the potential for an overdose if the total daily dose is given multiple times as individual doses. Another common factor which may lead to a calculation error is the interchange of pounds and kilograms. Patients often provide their weight in pounds. However, doses are usually provided in terms of kilograms. The following example highlights this issue. A two-year-old child was taken to a local family health center presenting with earache and fever. Following an examination by a physician assistant who was working under a medical directive of a physician, the child was diagnosed with acute otitis media. The physician assistant printed this prescription for clarithromycin and gave it to the child's parent. The prescription was also taken to a community pharmacy for processing. Upon checking the prescription for appropriateness, the pharmacist asked the parent of the child's weight and confirmed the purpose of using the medication, which was for an ear infection. Upon consulting an appropriate reference, the pharmacist confirmed the recommended dosage of clarithromycin for acute otitis media to be 15 milligrams per kilogram per day in divided doses every 12 hours. Based on a weight of 10.9 kilograms, the daily dose would be 164 milligrams per day and not the 700 milligrams per day as prescribed. The initial dose prescribed was therefore more than 4 times the intended dose. It would appear that the miscalculation was twofold. The daily dose was not converted to a single dose by dividing by 2, and the child's weight was not converted from 24 pounds to 10.9 kilograms. We've heard the phrase, "the error is human." That means anyone can make an error. Therefore, we cannot assume that calculations performed by other healthcare providers are always correct. In this example, the prescriber intended to prescribe 31.25 milligrams every 12 hours. However, he also wrote 1/4 tablet of the 250 milligram twice daily. As you know, 1/4 of 250 milligrams is 62.5 milligrams and not the 31.25 as intended. That is double the intended dose. Though computer-generated prescriptions can minimize medication errors due to illegible handwriting, be aware that new types of errors may be introduced, as the following example demonstrates. This preprinted prescription for amoxicillin was given to the mother of a 1-year-old child with acute otitis media. The community pharmacist, when checking the prescription, confirmed the child's weight, the indication for use, and the recommended dosage. On the prescription, the weight of 12 kilograms is correct. The dose of 80 milligrams per kilogram per day was valid. However, the logic in the computer is completely false. The correct dose was calculated to be 480 milligrams twice daily, or 9.6 milliliters of the 250 milligram per 5 ml concentration to be given twice daily. The printed dose was therefore only 1/4 of the intended dosage. I would now like to list a few recommendations to prevent these and similar errors. I believe there's an opportunity to standardize the way in which recommended dosages are stated on labels, on packages, and on product monographs to eliminate this ambiguity. When dispensing medications for pediatric patients, it's critical that we always collect the child's age and weight. And to facilitate weight measurement when the parent or agent is unsure of the child's weight, I recommend having a weight scale readily available. We should not rely on historical information because children do grow very quickly. We should always inquire about the purpose of the medication. This is a key piece of information that is often missing on prescriptions and must be collected. Pharmacists cannot assess the appropriateness of the prescription without confirming that the dose is appropriate. And this can only be done if the pharmacist is made aware of why the patient is taking the drug. And this is true for all prescriptions, not only for pediatric patients. We must always consult an appropriate reference to confirm the recommended dosage regimen of the medication and to ensure that the appropriate drug and dosage is being dispensed. We must always double-check dosage for pediatric patients due to the increased risk of harm. Ideally, we should have a second individual independently complete the calculation without prior knowledge of the results of the first calculation. It's critical to train all staff to perform pharmaceutical calculations. In the community setting, for example, there is no reason why a pharmacy technician or pharmacy assistant cannot play a role in checking the calculation. We must always assess the answer that we obtain to see if it's appropriate. Does the answer appear too high or too low? We must always use a calculator or another computing device to check the results for accuracy. Errors can occur even when performing a simple calculation. To demonstrate, let's perform a simple calculation without the use of a calculator. Let's take 1,000, add 40 to it, now add another 1,000, now add 30, add another 1,000, now add 20, now add another 1,000, now add 10. What is the total? Please use your chat box to provide an answer.
We're getting a couple answers in the chat box, looking like 5,000.
Okay, so the most common answer given is 5,000. The actual answer is 4,100. This demonstrates that even simple calculations can be incorrect if we do not use an appropriate calculator. In summary, I want to say that we should view prescribing, administration, and dispensing of drugs to pediatric patients as a high alert, high risk situation. It's critical that we gather all necessary information and double check all calculations to ensure that the right patient gets the right drug at the right dose. I want to thank you for listening, and I pass you over to Ambika.
Thank you for sharing those multiple incidents involving dosing calculations, and especially for pediatric patients. It's so important for us to always have an accurate weight in the correct units, the right dose per kilogram for the indication, and of course an independent double check of those calculations, because pediatrics are particularly vulnerable to harm if a dosing error occurs. This is actually just a resource that we've worked on here too, about the importance of getting the weight for pediatric patients. I'd like to invite the second set of speakers to describe a med safety program that enables continuous quality improvement and the important learning that stems from that.
Thank you, Ambika, for giving us the opportunity to present in this webinar. My name is Jim Kong. I'm also joined by my colleague, Lindsay Yu. We're both pharmacists with a community background, and we're part of the team that works on ISMP's incident reporting program for community pharmacy. So, even though this presentation will be looking at continuous quality improvement from a high-level perspective, behind every incident and statistic is a patient. And our ultimate goal is to prevent patient harm and improve patient safety. So I wanted to highlight some of the differences between community pharmacy practice and hospital practice. This is not a comprehensive list, but I wanted to touch on some of these points today in the context of patient safety. In community pharmacy practice, the pharmacist usually has greater contact with patients on a regular basis. Patients will usually directly seek out the pharmacist for counseling and other health-related issues, whereas in hospitals, the pharmacist will usually have greater contact with physicians or other healthcare professionals inside, either during rounds or helping to develop a patient care plan for someone that's newly admitted. In terms of the patient population, in community practice, you'll usually find ambulatory patients, whereas for hospitals, patients are typically more acutely ill and sometimes non-ambulatory. For pharmacy operations, community practice is relatively more independently managed compared to hospitals. Even if a pharmacy is part of a large chain or retail banner, each location usually has a limited degree of oversight from upper management compared to a hospital pharmacy, where there's usually more regular oversight from either the centralized pharmacy department or unit department within the hospital. Community pharmacy care is also more episodic. Treatment is based on received prescriptions or counseling. In the hospital, however, treatment is usually provided as part of a patient care plan that's monitored by either the clinical pharmacist team or the designated pharmacist for that specific department. And usually there's much better access to clinical information inside hospitals, so pharmacists are usually able to have a more clear picture of the overall state of the level of care for that patient. And finally, the last difference I want to mention is in community pharmacies, there typically isn't a dedicated person or team that specifically deals with incident analysis and review. This creates a more reactive situation for when incidents occur, whereas hospitals are more proactive and will usually have a dedicated staff, be it a pharmacist or pharmacy technician, that deals with quality improvement initiatives within the pharmacy. This has changed recently with the introduction of mandated incident reporting programs across different provinces. So now they're introducing a quality improvement coordinator inside community pharmacies, but historically this wasn't the case. So all these factors lead me to my final point, which is that due to the work systems within community pharmacies, pharmacists tend to find themselves in more isolated and siloed systems with less oversight and control processes to catch errors compared to hospital pharmacists. This makes community pharmacies more prone to medication errors, which is where a standardized continuous quality improvement program can make an impact by helping to catch system vulnerabilities to develop a safer medication use system. This is a map of how ISMP Canada analyzes the medication incident data we receive from our reporting programs. Once the incident data is entered and submitted, it undergoes either quantitative analysis or qualitative analysis. So quantitative analysis summarizes the incident data based on the numbers and can help to provide useful descriptive statistics such as charts, graphs, and frequency distribution tables. It also provides pharmacies with a starting point for discussion on medication errors and can help to highlight the trends in the frequency and type of incidents. Qualitative analysis refers to the analysis of the narrative data. So this type of analysis helps to identify the common themes that reoccur in incident narratives from either a single incident or a group of incidents. And Lindsay will touch upon this later on in the presentation. So in these next few slides, I want to summarize some of the findings from a 7-year study ISMP conducted with Nova Scotia using community pharmacy incident data. This study analyzed a total of 98,097 incidents. Of these, 928 incidents resulted in patient harm, while the rest were near misses or incidents that were caught before reaching the patient. In the analysis, or in the quantitative analysis of the data, the top 3 reported medication system stages were order entry, prescription preparation dispensing, and prescribing. The top 3 types of incidents reported were incorrect dose/frequency, incorrect quantity, and incorrect drug. The top 3 medications involved in incidents were levothyroxine, amoxicillin, and rosuvastatin. And this may be surprising since these medications are not necessarily high-risk medications, but it's also possible that the likelihood of a medication being involved in an incident is correlated with how frequently that medication is dispensed in the pharmacy. So that may be one of the reasons for this trend. And when we actually look deeper into the data, we found that the top 3 medications reported associated with patient harm were actually methadone, risperidone, and warfarin, which makes sense due to their the high-risk nature of these medications. So this was an example of the type of quantitative analysis we conduct for a continuous quality improvement program. I'll now turn it over to my colleague Lindsay, who will go over an example of a qualitative analysis.
All right. Okay. Oh. All right, thank you, Jim. Hello, everyone. My name is Lindsay. I work with Jim and the rest of the team here at ISMP Canada. I also practice as a community pharmacist in the GTA area. So to continue on from what Jim had presented, in addition to the quantitative analysis work that Jim had outlined, we also conduct qualitative analysis of community pharmacy data, particularly multi-incident analyses, which I'll be referring to as MIA for short. So what you see here are some examples of the many MIAs that we've conducted and published based on community pharmacy data. So these include medication incidents associated with transdermal fentanyl, QT prolongation, insulin, compliance packaging, methadone dispensing, vaccines, and many more. These are just a few of the numerous analyses that we've done over the years. And so to give you a better understanding of the content and format of these analyses, I'd just like to highlight one of our multi-incident analyses in particular, which is based on medication incidents associated with hospital discharge. Okay, so before I delve into the analysis itself, I wanted to quickly highlight what a multi-incident analysis is for those who may not be quite familiar with this particular incident analysis methodology. So multi-incident analysis, or MIA, is a method of analysis that maximizes analysis efficiency by analyzing a group of medication incidents sharing a common topic or factor. So this could be something like a drug class, age category, or drug, for instance. So all of the incidents that are retrieved for the purpose of conducting an MIA share a common thread between them, which is that they are all related to a particular topic. And the end result of completing an MIA is a more structured and in-depth analysis that yields themes and sub-themes regarding that topic, as well as potential contributing factors and subsequent recommendations to address any vulnerabilities in the system. And I've included a reference at the bottom of the slide for those who may be interested in learning more about the MIA methodology. Overall, though, it is a way of consolidating a vast amount of medication and incident information related to a particular topic into categories so that the analysis of these incidents is more organized and conducive to analysis. Now that we've established what an MIA is and what is involved, let's go back to the qualitative analysis on medication incidents associated with hospital discharges, as I mentioned before. Now, this was in the form of an MIA using exclusively community pharmacy incident data, i.e. medication incidents reported by community pharmacies. I've included the URL to this MIA publication on the bottom of the slide for your reference, for those who are interested in learning more about this particular analysis that we did. Now, the results and findings of the community pharmacy analysis that I just highlighted in the previous slide were included in another more broader analysis of the data from our national repository, looking at this exact same topic. So with this particular MIA, we again looked at errors associated with hospital discharge prescriptions, only this time we incorporated data from our entire national repository, consisting not only of community pharmacy data, but also data from our individual practitioner reporting database and consumer reporting database as well as the NSER program. In this way, community pharmacy data and the associated analyses contributes to CMIRPs. So once we retrieved the incident data pertaining to this topic from the National Medication Incident Data Repository, we then applied a set of inclusion criteria, and the data range spanned over a period of 6 years, and in the end, 134 incidents were included in the final analysis. As I mentioned, one of the outputs of conducting an MIA is the identification of recurring overarching themes amongst the incidents. So in this analysis, there were 3 main themes that were identified, each of which were associated with several sub-themes that the incidents could be further categorized into. So the first theme was related to challenges in creating accurate and appropriate discharge prescriptions. And an example of a sub-theme was failure of MedRec at admission, transfer, or discharge. The second theme was miscommunication of medication information, with one of the sub-themes being the misinterpretation of hospital computer-generated prescriptions that incorporate hospital system nomenclature. And lastly, the third theme was challenges encountered by community providers when processing discharge prescriptions. And one of the sub-themes was inadequate community pharmacy systems processes and checks. Okay. So let's look at an incident example which was under the main theme of miscommunication of medication information. So we have a patient who was recently discharged from hospital, was given a computer-generated discharge prescription that read warfarin 4 milligrams WRF. The community pharmacist interpreted WRF as Wednesday, Thursday, Friday. Upon checking with the hospital, however, the pharmacist discovered that WRF was a short form for warfarin used by that particular hospital to indicate its usual warfarin daily dose administration time. So this incident speaks to the need for clear communication of discharge orders and the need for medication reconciliation at patient counseling at discharge, which could have potentially averted any confusion by clarifying and fixing the WRF proactively. It also highlights the fact that systems don't work in isolation. The use of exclusive nomenclature or abbreviations within one institution can have ramifications for external organizations and individuals, especially when given the interconnectedness between hospital and community or the patient's home. If the pharmacist in this case hadn't checked with the hospital and went ahead with the assumption that WRF meant Wednesday, Thursday, Friday, the patient would have been at risk for subtherapeutic dosing of warfarin since it is supposed to be given daily. So to address these issues, a number of recommendations were determined. One of the recommendations is to implement standardized discharge processes to enable the creation of discharge prescriptions that are accurate, unambiguous, appropriate, and understood by all in the patient circle of care. Another recommendation was to engage patients and their caregivers during or before discharge to communicate changes in the medication regimen and to support an independent double check of the discharge prescriptions. I also wanted to highlight some great resources that were included within this bulletin that you may find useful in your practice. I put these links to the resources for your perusal. So the first link on the slide brings you to the safety bulletin that I highlighted just now, and the following 3 links are resources that can help address some of the system vulnerabilities that were outlined in the multi-incident analysis, and they also help to complement some of the recommendations that were made in this bulletin. These resources include a toolkit to help facilitate and ensure medication safety at transitions of care, i.e. hospital to home, as well as a document that outlines clinical requirements to facilitate appropriate discharge medication reconciliation. And finally, there's a document called 5 Questions to Ask About Your Medications, which can really help open up dialogue between patients and healthcare professionals regarding the patient's medication regimen, as well as their usage of the medications. So that was a brief overview of the analysis that we conducted regarding incidents associated with hospital discharge prescriptions. And this diagram illustrates the tenets of incident reporting, which include anonymous reporting, documenting medication incidents, including near misses, as well as continuous quality improvement action plans. It also includes incident analysis, both quantitative and qualitative, and finally shared learning through safety bulletins and other publications. So through highlighting the safety bulletin on incidents involving hospital discharge prescriptions, we wanted to convey that we often undertake analyses of the incidents within the data within a specific database, such as our community pharmacy data, but that any data analyses that we do of one particular database ultimately feeds into the national aggregate and any related analyses on a broader scope, which contributes to CMRPs and ultimately facilitates shared learning. So that concludes our presentation. I'd like to thank you very much for your time, and I'll turn it back to Ambika.
Thank you, Jim and Lindsay, for describing the importance of medication incident reporting to facilitate shared learning and continuous quality improvement. We'll now get into the observatory for some quick med safety updates. First up is a quick update from Health Canada describing incidents sent to them regarding labeling and packaging.
Hi, my name is Hélène Perrier, and I'm part of the patient safety section at Health Canada. Health Canada reviews medication incidents. Oops, where's the slide? There we go, sorry. Reviews medication incidents where a drug product, a name, label, or package may have contributed to the error. The section consists of healthcare professionals from both pharmacy and nursing backgrounds, all of whom have a current or recent experience in a variety of practice settings. Health Canada can take action when there's been an incident, even if the medication error was intercepted before getting to a patient, or even from a report of concern. So I wanted to talk today about, you know what, sorry, I'm just a little mixed up here with my slides. I wanted to talk today about a literature report that was published by Ian Stewart, who you've already heard speak today, regarding in the Ontario College of Pharmacists Pharmacy Connection last summer, so summer of 2017, with regards to an incident that occurred with APO-AMOXI sugar-free suspension. So this incident involved the 125 milligrams per 5 ml powder for oral suspension. It's a 300 ml quantity that was required, and inadvertently the person preparing the product picked up a one bottle of the 150 ml formulation, the sugar-free formulation, and one bottle of the regular formulation instead of 2 bottles of regular. The directions for reconstitution are different for each of these formulations. The sugar-containing powder requires adding 103 milliliters to the powder to provide 150 mils of volume and a concentration of 25 milligrams per mil, whereas the sugar-free formulation requires addition of 148 mils to provide the same final concentration and final volume. In this incident, both bottles were mixed using the same amount of water, resulting in an incorrect concentration being prepared for one of the bottles. Both bottles have a very similar appearance, and both bottles carry the same drug identification number, 628131. The error was fortunately caught by the pharmacist before the prescription was issued to the patient. So there are the products. As you can see, there was 2 issues that fell within Health Canada's mandate that were identified in this article as contributing to the error. One is the lookalike products, and you can see here, this here is where it says sugar-free, right here, right underneath the brand name. And the other issue that contributed to it was the fact that these bottles carry an identical DIN. The right side of this photo captures the product entries in the Health Canada Drug Product Database that's posted on Health Canada's website, and each of these products was approved originally with a distinct drug identification number. This file is still being worked on here at Health Canada, so we can't provide further details at this time on how these issues are being addressed, but they are being addressed. So Health Canada hears from users when there is a safety concern, and you can report issues if you find an issue that you feel is a safety concern regarding the name, label of the package, or in this case, the drug identification number. Please report to ISMP or to Health Canada. You may recall a few years back the issue that was related to the DIN with Fragment prefilled syringes. These are images of 3 different sizes of Fragment prefilled unit dose syringes, 5,000 units, 7,500 units, and 18,000 units. All of these sizes, when they were first issued, carry the same DIN. And the DIN identifies very specific characteristics of a product, and in this case, they were issued with the same DIN because the solution inside each of these syringes was the same concentration. So the DIN includes 6 product characteristics: the manufacturer, the brand name, the ingredient, the strength of the ingredient, and this is bolded because, as I said in the Fragment example, the strength or the concentration of the ingredient was the same for all the products. They were just different volumes, and that generally would not merit, if you will, a separate DIN. Medication errors, of course, occurred and were reported where patients were given incorrect doses of Fragment, and confusion due to identical DINs was noted to be a contributing factor to these errors. In 2010, Health Canada revised its policy to permit the issuance of unique DINs for unit dose pre-filled syringes that are the same strength but carry different package sizes, thus different doses. And on a case-by-case basis, since 2010, I know all of the injectable anticoagulants have been revised so that each size carries a different DIN, and other packages as well have been evaluated on a case-by-case basis. For example, sachets where there's a 2.5 grams of cream versus 5 grams of cream when the entire contents of the sachet is to be applied is an example where different DINs have been applied. So again, to repeat, if there is a product that you feel is prone to errors or confusable because of an identical DIN with a different size, please share that information with us and we can take a look at it.
Thank you very much for those interesting cases. Particularly with the DINs, we do like to think of them as a unique identifier for a given product, but it's always important to remember what those DINs are representing. So we'll now have a CPSI update on their med safety initiatives.
I'm Steve Rutledge. I'm with the Canadian Patient Safety Institute, and today I'd like to bring to the table a few updates from CPSI. The first is through our Shift to Safety initiative. CPSI is pleased to announce a new 6-part webinar series coming up that is going to be focused solely on knowledge translation and implementation science. So what you can expect from these webinar series is to consider how contemporary approaches in knowledge translation and implementation science can be directly applied to enhance your current patient safety work in terms of a broader understanding of knowledge translation and implementation science, as well as concrete steps, approaches, and tools for the rigorous application of this science in your day-to-day work. So the webinar series is broken up into 6 one-hour sessions designed as a full suite, as you can see on the slide right now, with each session building on the previous session. Ideally, these would be suited for people who are able to participate in all 6, but if that's not possible, you can still register for independent sessions as well. All the sessions will be recorded and will be available for download on our website should you miss them. There's some fantastic speakers and researchers and leaders in the field set up for the webinar series, so I really encourage you to check it out on our website, Shift to Safety, as well as our Patient Safety Institute website as well. The first session's coming up not too far away, and then we have them going up right until June as well. So the second piece of information I'd like to share is back in 2016, late 2016, Health Canada hosted a national opioid conference and summit where close to 40 organizations from across the healthcare system, ministries, other health organizations right down, made a series of commitments to produce some products, guidance materials, and tools to help address the current opioid crisis in Canada. So some of these commitments, a number of products came out, which are now coming up on your screen, and they're now very much widely available on the Canadian Centre for Substance Abuse's website for your use in your improvement efforts. So a few examples are provided, and I'd really encourage you to check out the information on the CCSA website, as more information over the next couple of months will continue to be posted up there and is available for your use in your improvement efforts. That's it for me. Back to you, Ambika. Thank you.
Thanks, Steve. So thank you to all our speakers for the excellent learning presented today, and we'll now turn our attention to the questions that we've received throughout the webinar, and then we'll allow our speakers to elaborate.
And we've received a number of questions, so thanks for your enthusiasm, and we'll get through as many as we can in the next 10 minutes or so. So our first question is for Ian Stewart regarding pediatric dosing, pediatric calculations. And the question reads, shouldn't the prescribing physician do the initial calculations then the pharmacist could do an independent double check. And I think maybe elaboration upon what's the role of the prescriber and the pharmacist in this case, and how do they work together?
I believe certainly the prescriber and the dispensing pharmacist have a key role to play in ensuring the right patient gets the right dose. Clearly, the physician should perform the initial calculation and prescribe the correct dose, but we know that humans are fallible and errors can occur. So the pharmacist must assess each and every prescription to ensure it's appropriate. So yes, it is the pharmacist's responsibility to ensure that the right dose is administered. So he or she should not simply assume that the prescriber has prescribed the correct dose of the example I showed. So yes, I believe the pharmacist should, and I know it's challenging in community pharmacy because sometimes the pharmacist is by him or herself, and that's why I'm thinking, as I mentioned, pharmacy assistant can certainly play a role in double checking. I think someone made a comment that could the parent play a role, and certainly there's certainly no harm in asking everyone, and certainly patients and caregivers can play a critical role in preventing errors.
I think you've sort of outlined nicely or provided a great example how, we can all play a role, even as a parent or as a prescriber or as a pharmacist in medication safety. Our second question, you provided some compelling incidents and useful recommendations, but once the calculations are done and the dose determined, prescribers and pharmacists rely on the patients actually to get the medication into the child. They rely on them to prepare and administer the correct dose. Do you have any advice on what sort of devices are most useful, most safer, oral syringes or small cups or anything like that?
A good question. I think it's critical to ensure that the appropriate measuring device is given. For example, most community pharmacy gives oral syringes which goes from 1 to 10 mils, but if the dose is only 0.5 mil, I would not recommend providing that kind of measuring device. So you need to be flexible and give a measuring device to ensure the patient gets the correct dose. A device that the markings is clear. I would also go further and suggest that you actually place a mark on the syringe, the oral syringe, pointing out exactly the amount of dose to be given. Some suppliers actually sell a dose marker, and I may not be using the right term, but it's something you actually stick on the syringe that marks exactly where the medication should be withdrawn up to. So certainly providing an appropriate dosing measurement is critical.
Thank you. We'll move along to our CFIR program with Jen and Lindsay. Our first question is, what you presented in the community is quite different from what we see in a hospital facility. In particular, the top 3 medications in the facility, and you alluded to this a bit, are opioids, anticoagulants, and insulins. And we know that all of these are prescribed in the community. And do you have any further thoughts on why there is a difference between the community and the hospital facility?
Yeah, that's a great question. So from the study that we presented in the webinar, the top 3 medications, the trend for that was most likely due to those drugs being the most dispensed within that 7-year span by those community pharmacies. If you actually look at the full data set, and if you look at the top 10 medications reported, opioids are on that list, as well as other anti-hyperglycemic medications. It's just the top 3 didn't include opioids, anticoagulants, and insulins. But I also did highlight the fact that when we did a secondary analysis of that same data and looked at what were the drugs that actually caused the most patient harm, warfarin, so an anticoagulant, methadone, and opioid, those drugs were on the top 3 list.
And you did have a slide on the number of differences between the community pharmacy milieu and the hospital pharmacy enterprise. And the second question sort of states, community pharmacists may be under different pressures than hospital pharmacists, such as the business and financial pressures of running a retail storefront, of hiring and firing, seeing more of the business side of a pharmacy. How has this program been received by community pharmacists, and has there been a good response to this?
Yeah, so I can definitely understand that that's the current environment. But I can say that from speaking directly with pharmacists, technicians, and assistants on the front lines, the program has been well received. Despite, the pressures of the current sort of retail environment, I think pharmacists have that desire for shared learning to engage in continuous quality improvement and to improve medication safety. So, some of the comments that I've received was that incident reporting helps staff members become cognizant of the types of errors that occur, and it makes them more vigilant in their practice. Because once you become aware of the types that, of things that can go wrong, it gives them that awareness to try and put it in safeguards and avoid making those same mistakes again. I think another thing that really stuck out at me when I talked to these pharmacists was that this program has enabled the presence of an open culture where staff can discuss errors openly to make improvements within the pharmacy locally. So I think overall, there's been a good response from pharmacies and staff on the frontline level, and our program aligns with the recently mandated incident reporting programs by pharmacy regulatory authorities.
Thank you. We'll move along to Health Canada now. We have a couple questions for Health Canada. The first one is, I certainly appreciate look-alike, sound-alike products, but have you ever come across look-alike DINs? And the question goes on to read, I'm thinking of a brand of diazepam that had consecutive DIN numbers for different strengths, and there were report of errors based on that. And I think within this question, it may be an opportunity to elaborate, how do you select or how do you create the DIN numbers for each product?
Thank you. That's a really good question. For a number of years now, the DIN has been generated by a random process. In the past, and probably for this particular example that was stated of the diazepam, because it's an older drug, the DINs were issued sequentially based on the strength. So if there were 4 strengths of a product, then the DINs were 01, 02, 03, 04, for example. But again, due to errors and concerns expressed a few years ago, a number of years now, the DINs are randomly generated when the product is approved, and they're not sequential anymore. Unfortunately, that still means that there's a chance that there would be look-alike DINs even through this randomly generated process. For example, when the when the different sizes of fragment were reissued with separate DINs, they were, I think it's just, I'm not 100% sure, but I believe it's just the last 2 or the last 3 digits are random as opposed to the entire DIN. But when they were generated, one of the sizes of fragment, unfortunately, only had a 2-digit distinction from the original DIN, which results in a bit of a look-alike situation. Unfortunately, what we found out was that once they push the button on that random number generator and a DIN is generated, it cannot be discarded. So one of the ways that this sort of risk of look-alike is being mitigated is by on the label where either the last 4 or the first 4 digits of the DIN are, usually the last 4, or the last 5 are enlarged relative to the rest of the number.
And our second question is a bit of a comment and actually a bit of a report to Health Canada. And it has to do, again, with similar DIN numbers or identical DIN numbers. And regarding drug products that have the same DIN concentration but varying pack sizes, this particular facility has an example of the Diastat rectal gel, which does have 3 pack sizes, with which I assume identical DIN numbers, which leads to very confusing dispensing and reports of near misses at their own site. So I would submit that that's a report back to you, Health Canada.
In fact, we have been made aware of this situation, and we are currently addressing it, so we're on it.
Terrific. That's the value of reporting in action here. So I'd like to thank everybody, and we're just going to say a few words about what happens next with our Med Safety Exchange webinar series. And this marks the end of our first season, which is really the pilot season of this program. So thank you all for participating, and thank you especially again to all the presenters for all the number of compelling stories, the important analyses, and the safety ideas and strategies throughout this first 6 months and 6 broadcasts of the Med Safety Exchange webinars. We all hope, the presenters and ourselves at ISMP Canada and CPSI and the other contributors hope that you've taken some of these ideas back to your own institutions and workplaces. And we also appreciate the insightful questions and comments provided by the audience. I think that really enriches the webinar. And certainly thanks to all of our participants for joining the discussion and helping to share the learning. Without you, again, none of this is possible. We will be taking an evaluation hiatus to account for all the feedback we've received over the past 6 months or so, and all your suggestions, all your comments, and your thoughts about what you need or what you would like this program to be. So we'll spend the next few months reconfiguring the webinars in the best way to address these comments and respond to your needs. And so it's even more important now in the next few minutes or in the next week or so to please fill out the poll that's available at the end of the webinar and submit your comments back to us, to Ambika or through info@ and about the Med Safety Exchange. And we particularly need your feedback, I think, on the value you see in this program, either the current value or things that would make it more useful to you and your facility or whatever it is you do at work. And we really want to see ways of making this better. And we're also interested in your thoughts on webinar scheduling. These 6 webinars have been over the fall and winter months as part of the pilot attempt. If we do anticipate around 6 to 8 webinars per year, give us your thoughts on what you would prefer the schedule to be. Would it be most months of the year or the fall, winter, spring months? Would it be every other month if we could get 6 in? Which would work better for you? How are you most likely to fit it into your schedule? And we also want to know what's working well, what could make this forum even better, so please continue throughout the intervening time to suggest ways. And we want everyone to continue to be part of the Medication Safety Exchange, whether it's incident analysis, interesting case, medication safety initiative. So please email us to share the learning. And if you recall CPSI's presentation from last month, Steve noted the upcoming webinars will be part of Canada's contributions to meet the World Health Organization's Global Patient Safety Challenge of Medication Without Harm. Future webinars will provide updates on this initiative as well as periodically highlight the 3 WHO Global Challenge focus areas that are high-risk situations, polypharmacy, and transitions in care. We look forward to your continued support and your ideas to contribute to the program. All medication incident analyses, all the projects, all the stories you contribute are extremely valuable, so please don't hesitate to share. Webinar dates for the 2nd season of 2018-2019 will be posted on the website sometime in April of this year. And this will happen once we collate your feedback and determine on how we're going to program for the coming year. And we're really aiming to restart in late spring with our 2nd season. However, as always, you're free to binge watch previous webinars at any time via our website. So I hope you all have a wonderful rest of the day, and we'll see each other again soon.